E wave is lost, no energy, no relaxation or poor relaxation, poor movement, and the velocity drops, and you try to compensate for that by squeezing harder on the atrium, which gives you a bigger atrial, reversing the ratio. Type 2, 20% 5-year survival rate. E wave goes really high due to increased left atrial pressures and diminished compliance of the left ventricle, and you have no more ability to contract the left atrium. A wave falls off. Tissue Doppler looks like this, and here's the A wave, and you'll notice it's smaller. One of the most sensitive findings in this disease is the tissue Doppler, the E wave collapses. This little E wave right here just sort of just goes back up into the baseline. It's really quite fascinating. And it's what you're doing is you're seeing displayed before your eyes inadequate filling, which results in a stroke volume of 50% of normal, which results in an output that will depend on your heart rate and an effective microcirculation, which will depend on adrenaline, with it or without it. And God help you if you run out of adrenaline or end up having pain, which suppresses vasomotor. How this works. And that's not always expressed in this particular value. So there are people, for example, who may have pretty good-looking numbers that don't look too bad, but they nevertheless have diastolic dysfunction, the most sensitive measure of which is the IVRT, isovolumetric relaxation time. The timing between aortic closure and mitral opening is the time interval by which all the energy is virtually expended. It's measured in milliseconds. And if you have low energy, the IVRT prolongs because you take more time, if you have less energy, to dump the calcium out of the cell. The IVRT, therefore, may be the best number to measure energy in the cell. So there's a lot of parameters. Also, there's the deceleration time in milliseconds from this deceleration time of the E wave. The point is here that we can take echo and we can actually measure numbers to quantitate the degree of diastolic dysfunction. And once we know that number, although we understand that that number, whatever it is, may be normal or not normal, it still is a number that reflects energy. It doesn't reflect how you're compensated for it, doesn't reflect microcirculation, but it's a number that we can start with. And if we're making progress in treating you, those numbers should get better over time. So whatever number it is, it should get better over time if we're treating you properly for this problem. Okay. Oh, we're getting there. Let me then move to this important slide. I call it the order of sacrifice. If you lose cardiac output, which organ system is sacrificed first, then second, then third, then fourth, and fifth, and so on? The first organ sacrificed, should this occur to you, is you will sacrifice microcirculation to the skin. Normal people pump 0.5 liters per minute to their skin. If you walk out there, you will pump 3 liters a minute to your skin, or you'll overheat. Think about this. In here, we're pumping 4.5 liters per minute. Walk out there, you're pumping 3 liters a minute through your skin. Well, what if your output's only 5, or 4, or 3, which is not uncommon? What if your output is 3 liters per minute and you need 3 liters to walk outside? Then that leaves nothing for your brain. So guess what? Do you sacrifice your skin, or do you sacrifice your brain? Your skin first. Skin goes first. And there goes your thermoregulation right out the window. Can't stand heat, and as you adjust your thermostat regulator, you then become cold and can't stand cold. You can't stand heat, you can't stand cold, and you'll kill for control of the thermostat. Don't touch that thermostat, I've got control. Then come your muscles and joints. Sacrifice those next. Sacrifice microcirculation to the muscles and joints, and they become slightly hypoxic. You release VEGF. You become leaky. You get joint pain. And also, if there's a mismatch, you'll get pain. So muscle and joint pain comes next. Then comes your liver gut. You get that. Suddenly, your food choices become more and more limited, more and more food intolerances, and pretty soon at the end, like I got down to 2 foods in the end. I could only eat pineapple and sushi. That's all I could eat. Everything else made me sick. That's it. And then in the very end, I could only eat pineapple. That's all I could eat. Nothing more than a reduction of cardiac output causes this. That's all it takes. And when they repaired my heart, you know what happened? The very first thing I noticed, I could eat anything and everything. I became a human disposal unit. They would bring me anything. I could eat anything, and it just tasted so good, and I just ground it up in my gut and got the nutrition out of it. And my wife was bringing me hot dogs and hamburgers. I said, just bring it on. They fed me 5,000 calories a day because now I have the cardiac output to deal with that. Converse is true if this is lost. You can't eat anything. Then comes your brain. As the brain goes, microcirculation affects the brain. Although the brain is relatively preserved, it's more preserved than most things. Sometimes I think the problem with the brain comes more from the consequences of the gut. Consequences of gut issues may be the bigger issue, and finally the consequences potentially of ischemic reperfusion syndrome. So I'm not exactly sure that the brain, and you'll notice in Peckerman's paper, did he say, and he said this, that brain dysfunction did not seem to correlate with cardiac output. He said exactly that. He said exactly that. So the brain may not be so much because if you read the textbook of physiology, brain microcirculation is so tightly controlled, you can have incredible drops in cardiac output and maintain cerebral blood flow. The problems for the brain, I think, come from loss of gut. I think loss of control of gut microcirculation is when your brain gets hit, and then if you have to squeeze down too hard on your gut to maintain your output and get ischemic reperfusion issues. The heart can manifest this as of course, chest pain, often atypical, negative cath, no coronary disease, but chest pain that mimics heart attacks. You have arrhythmias. You'll have mitral valve prolapse is linked to this issue. Arrhythmias, shortness of breath, dyspnea on exertion, on and on. Then you get to the event horizon. When this microcirculatory problem impacts the heart itself, you can get to a vicious cycle, and then rapidly will lose your lung and kidneys, hepatorenal failure, and then death. And I got all the way down to this. I experienced the whole thing going down slowly, and the whole thing coming back up fast. So just almost the whole thing just kept going in reverse as I got better, including a near-death experience here. But this is when my liver and kidneys failed. That's why they gave me 48 hours to live. Treatment of CFAC. I think the most compelling idea, first of all, is there treatment for diastolic dysfunction? If you read the textbooks and the literature, bottom line, and I've read pretty much all the modern textbooks on this subject, bottom line is there is no effective treatment for diastolic dysfunction. That's the bottom line. The most common drug used has been calcium channel blockers. The problem with using calcium channel blockers in this disease might be that it could drop your pressure further out, which would unpressurize your system and put even more load on your failing adrenals. So it's not a great idea in this disease, although perhaps in someone that's a little better than worse might find some benefit from calcium channel blockade. Beta blockers have been used, but less successfully. Bottom line is what they say is there really isn't any treatment. So that's another reason why cardiologists aren't going to exactly gravitate you to put the fire out, because they don't know what to do for this. Yes? Yeah, there are some other things out there, but you have to contrast the difference between supporting the heart in its diastolic dysfunction versus treating the energy problem, which is the cause of it. And what you just mentioned doesn't do that. This is an incredible article. It's published in The Lancet, July 2004, by Drexler out of Germany. He's a professor of cardiology in a German hospital in Hanover. You can get this right off of Google by actually, you can't get the article, but you can get a lot of the AP News Wire stories when this was published by typing in Drexler and type in bone marrow transfer and myocardial infarction, and you'll get this article and comments about it. But what they did was they took 60 people that had a heart attack. And this is the left ventricular function. This is a measure of how well they're pumping, the status of this myocardial cell and its pumping efficiency. And at 3.5 days after the MI, all 60 people had routine coronary angioplasty and stent placement for their heart attack. Their cardiac left ventricular ejection fraction was sitting at about 10%, which means about an 80% wipeout of their left ventricular function, and they were in failure, left ventricular failure.